Hi there, my name is Hassan Sallam, and today I'm going to talk to you about the stimulation protocols used in IVF and ICSI. Please use your headphones or attach the speakers for a better quality of sound. Now, this is the presentation layout. I'm going to talk first about the FSH and LH preparations, the GnRH agonist protocols, then the antagonist protocols, then the mild stimulation protocols, and finally the double or the Shanghai stimulation protocol. Now, what about the FSH and LH preparation? Now, this is, of course, Stepton Edwards in an interview they had with the media just after the birth of the first baby, Louise Brown, in July of 1978. Now, if we can remind you that this first pregnancy of IVF of Louise Brown was done in a cycle which was an unstimulated cycle. There was no stimulation there. Stepton Edwards has said that they have tried clomiphene, they have tried HMG or FSH, and it didn't succeed. And then when they reverted to non-stimulated cycles, spontaneous cycles, then the first pregnancy happened in this spontaneous cycle. And in their idea, they said they think that clomiphene and HMG may be affecting the endometrium, therefore the pregnancy doesn't happen. So what were they doing? They were admitting the patient in the hospital, and then around day 7 or 8 of the cycle, then measuring the LH in urine, then starting to measure it every 3 hours. And when they had a defined rise in this urinary LH, they would go for ovum collection 28 hours afterwards. Now, what is a defined rise? Their definition of a defined rise was a 50% rise in the LH concentration in the urine over the mean of the previous 3 readings. And as I say, if there is a defined rise, they would go for ovum collection, which was done obviously at that time with laparoscopy. They would do it after 28 hours. And why is it 28 hours? Because there is a difference between what we would call a defined rise or between starting our calculation before the start of the rise. So if today we give the HCG before any LH rise, so in this case we really have to add this 6 or 8 hours of a difference, and then we would go for our collection today at 36 hours or between 32 and 36 hours. Well, the Australians didn't buy this. Stepton Edwards, of course, they are the leaders, they are the pioneers, they are the first people who have done IVF. But they said something which was not evidence-based. They said that clomiphene doesn't work and HMG doesn't work. Well, the Australians didn't buy it. And this is Professor Cardwood and Professor Alan Troughton in Monash Institute. They say, why? They said, why doesn't it work? We do it all the time for patients who are coming just for ovulation induction, and it does work, and they become pregnant in the same cycle of clomiphene citrate. So we don't agree that there are changes in the endometrium, and they started doing their IVF with clomiphene citrate stimulated cycle, and they achieved the first pregnancy in 1980, and this was incidentally the fourth IVF baby in the world. Now the Americans did the same. They said, well, we have been using HMG for some time now for ovulation induction in women who do not have ovulation, not for IVF. So we will do the same for IVF cycles. And they started doing the IVF using HMG, human menopausal gonadotropins, meaning FSH preparations, and they succeeded in their first pregnancy, which was born on the 28th of December in 19 1881. This was Professor Robert Howard Jones Jr. In fact, his father was also Howard Jones, and his wife Georgiana Seeger, and she took his name, so she's Professor Georgiana Seeger Jones. Both of them were actually professors at Johns Hopkins University, and in fact, they were asked at that time, how come that the British have done the first IVF and the Australian have done IVF, and how come that America doesn't have an IVF? They said, just give us some bucks, give us some money, and we'll do it. And when Johns Hopkins University was not quick enough, the university in the next door state, which is the state of Virginia, Eastern Virginia School of Medicine, they told them, come over here, we will build a whole institute for you, which is the Jones Institute, and this is where the first IVF was done. They were, of course, friends with Professor Robert Edwards, as you can see from this. So what do they use? They used HMG, which is also called Menotropins. And this is Professor Bruno Lunenfeld. When he was in Zurich, he did a lot of work separating the FSH from the urine. So from the urine of menopausal women. Of course, we know that menopausal urine contains high levels of FSH and of NLH, and this is what he did. He separated the FSH, he purified it from the urine of menopausal women. And the first preparation for clinical use was called Pergonal 25. It contained 25 international units, and it was registered in Italy in 1950. And Professor Lunenfeld used this preparation for achieving pregnancy in women who had no ovulation. And this is the first pregnancy, which was published here in a French journal, as you can see, in fact, measuring the hormones from the start of the stimulation of the cycle until the end of the pregnancy. Professor Lunenfeld, of course, now is in Tel Aviv University, professor continuing his work in Israel. And this is how the urine was collected. I'm not going to go into details, but the urine was collected from menopausal women, usually from convents, but from any other source of menopausal women who could provide the urine, and then it was prepared into kaolin cake, and then from there it was purified to obtain the FSH and the LH, which should really be called human menopausal gonadotropin. Then, in 1963, Pergonal 75 international units was registered in Israel, and 2 years later, it was registered also in Italy. And Professor Lunenfeld at that time recommended using it between 150 to 225 international units for the hypo ladies, the ladies who have no cycles. They have no activity in the hypothalamus pituitary, those we would call today WHO group 1, and 75 to 150 for anovulative women who are normal gonadotrophic patients, those we would call today WHO 2, including, of course, the PCO patients. But standardization was still a problem, as we will say later. And this was the classification of functional infertility, which was proposed at that time. It was a group, WHO group, expert group, headed by Professor Lunenfeld. As you can see, it says functional infertility, but if you look carefully, you will find that group 4 is not really functional, genetic tract disorders. And in fact, group 5 also, it's hyperlactin with pituitary lesion. So it's not exactly functional. There is a lesion there, there's something physical. But anyway, now we know that the new classification contains only the first 3 groups. So it's either hypo, or so the hypothalamic pituitary failure, or hypothalamic pituitary dysfunction, or ovarian failure. We'll talk about this later. So these were the two groups really which were to which HMG was used for treatment. But from the beginning, it was clear that HMG can produce hyperstimulation, which can be quite serious, leading to the hyperstimulation syndrome. Some of the cases could be very severe. So from the beginning, there was the recommendation that you cannot use this treatment like this. You have really to monitor your treatment. And there were different methods of monitoring, starting with vaginal smears. As you can see in this early book on infertility by Professor Lunenfeld and Professor Vaclav Insler, a beautiful book at a time when very few books on infertility existed. So the monitoring could have been done by vaginal smears, or by monitoring the cervical mucus, or measuring total estrogens in urine, or then measuring plasma estradiol in blood, or the ultrasound, as we will say. So how do you monitor with vaginal smears? You look at the smears. We know there is the um, vaginal smear score, which is the percentage of the parabasal cells and the basal cells and the intermediate cells, then the superficial cells. And if the woman is producing enough estrogen, then we will have a preponderance of superficial cells. If she is not responding yet, we will have a majority of basal and parabasal cells. So you keep giving your HMG until you have a good score showing many superficial squames, meaning that the woman has reached a certain amount of estradiol before giving your HCG. And this is how some people used to monitor HMG at that time. The other method was to use cervical mucus, and these are the changes which we know happen during this cycle. As you can see, towards the middle of the cycle, the cervical diameter is a little bit, the cervix is a little bit open. The amount of mucus is higher. Spinnbarkeit is present. Spinnen in German, of course, means threads. Spinnbar, threadable, and Spinnbarkeit means threadability. So this is the ability of the mucus to make threads, as you can see here. And again, ferning, by putting the cervical mucus on the slide and leaving it to dry. The sodium chloride crystals will deposit, giving you this ferning shape. And of course, this goes with the basal body temperature. So if you were examining the lady and looking at the amount of mucus and its stretchability, you could know, if you are expert enough, that she is now producing enough estrogen for HCG to be administered. The other method was the method of Brown for measuring total estrogens in urine. It is a physico-chemical method, meaning that you depend on the physical and chemical properties of the compound to measure it. And as we all know, estradiol, estrone, and estriol, they all have a common A ring, which is an unsaturated ring, as you can see here. And depending on this chemical structure, Professor Brown suggested to add the Kober reagent at the Ittrich reagent, and this will give you a color. And on a colorimetric method, you can measure the total estrogens in urine. Obviously, in this case, you cannot differentiate between estradiol or estrone or estriol, but if you're giving HMG, the majority of your compound, of course, will be the estriol, or actually its metabolite in urine. The method which came after this is to measure plasma estradiol directly. And of course, this could not have been done earlier, because Yalow and Pearson received the Nobel Prize in 1960 because of their discovery of a method called immunoassay. And that time they used to use radioimmunoassays, and it is only at that time, after this discovery, that we could know the interplay between the different hormones, this beautiful um, interplay between hormones that we take today for granted. This was not possible before 1960. In fact, this interplay between different hormones, the FSH, the LH, the estradiol, and the progesterone, was produced in 1970. So by that time, by 19, um, by the late 70s or 19, the early 80s, um, the measurement of estradiol could be done by radioimmunoassay methods, and this was used to monitor gonadotropin. As you can see here, you keep giving HMG until the levels reach between 100 and 1500 and 2500 picomoles per liter. Of course, picomoles per liter is different by picograms per milliliter. So you really have to divide by 3 because the molecular weight of E2 is 272. So if you're using picograms per milliliter, so it's going to be around about a third of this amount. Anyway, so when you reach this required level, you give the SCG, as you can see here. And that time, Professor Lunenfeld had suggested to give the injections 3 times a week. So the woman would come on Monday, on Wednesday, on Friday, as you can see here, day 1, day 3, day 5, and then day 8 here, and then by day 10, in this particular example, the levels had reached the required levels, so she was giving the HCG on day 10, as you can see in this picture. Then came the ultrasound scanning of the follicles. Of course, when Steptoe and Wedworth produced their first pregnancy in 1978, the first IVF pregnancy, they could not see the follicle by ultrasound. There was ultrasound at that time, but it was primitive, and he could only use it to look at ovarian cysts, for example, or at the baby to see the head of the baby, maybe to measure the biparietal diameter, but the follicles were too small to be seen. But by the late 1970s, 1978, 79, came the sector scanners, which allowed us to look through a full bladder, transabdominally, of course, because the transvaginal was not invented at that time. Transvaginal ultrasonography came in 1985, but this is the way we used to do it at King's College Hospital. I had the honor and pleasure of working with the godfather of ultrasonography in obstetrics and gynecology, Professor Stuart Campbell, as you can see his name here on the paper, and Professor Charles Roddick, who became later the professor and the chairman at University College London, and Professor William Collins, my mentor in my PhD, and my colleague Anthony Marino. And as you can see here, this was the first paper in the English literature actually, to say that you can monitoring gonadotropin therapy without measuring hormones, just by ultrasound scanning of the ovarian follicles. And this is how it used to be done. The woman would come on at the beginning of a spontaneous or induced cycle, and she would get her HMG and then come again after 2 days. As you can see here, again, it was a Monday, Wednesday, Friday, and then the following Monday. And by the time the follicle reaches anything between 20 and 25, today we would say 18 and 20. It really depends on the calibration of your machine, on which velocity of sound it is calibrated. So with the machine we were using, we would wait until 20 millimeter before giving our HCG, and as you can see, I used to see the patient 2 days later to make sure that she had the corpus luteum, that the follicle had collapsed, actually ovulated, and then 1 week after that to measure the progesterone and have another look at the corpus luteum. This is at least what we used to do at that time. But of course, there was always the possibility of ovarian hyperstimulation, particularly in women with polycystic ovary syndrome. So the drug companies, in particular Serono, who had produced the Pergonal, which was the only available preparation at that time, there was also another preparation which was a Humigon, human menopausal gonadotropin, Humigon, which was produced by Organon. Again, but Serono came at that time and they said maybe the hyperstimulation is due to the high LH content in our uh, preparations, because the preparation at that time contained 75 international units of FSH and 75 international units of LH. And then we know that ladies with polycystic ovary syndrome, they already have a high LH over FSH ratio. So the reasoning was that if you give them fewer amounts of LH, maybe you could this could prevent the ovarian hyperstimulation. So they came up with the purified HMG, and they did this by using polyclonal antibodies. As you can see in this diagram, this is a column. You put your column and you put the adsorbent, and you can add to this adsorbent an antibody to LH, and then you put your preparation on the top, and then it will go through, but the LH is going to be attached by the adsorbent, as you can see here, so that what you would collect at the bottom of your column will be a preparation which contains less LH. So if you use polyclonal antibody, you get a purified HMG. But if you use a very specific antibody, which is a monoclonal antibody, then you can have a highly purified HMG. At that time, the scientific name of this preparation is urofoliotropin or urofoliotropin highly purified. So we had on the market at that time Pergonal, which contained 75 FSH and 75 LH, Metrodine, which contained 75 FSH and 25 LH, and Metrodine highly purified, which contains 75 FSH and maybe less than 1 unit of LH. In order to be marketed in the UK, a field study had to be done, and I was honored to be the principal investigator in this study, and this was the result, as you can see, of the study. So by 1990, people started to use these preparations more and more. There was a high requirement for HMG. The requirements increased 100 folds, as you can see here, because everybody started to do IVF at that time. And there were different problems. Again, as you can see, there were limited sources, the lack of regulatory control, of course, as we said, cross-contamination could not be avoided, and many. So all these reasons led the drug companies to start looking for another method of manufacturing the FSH. And the response was in recombinant technology. This is, of course, the pituitary, and we know that the pituitary has the chromophil cells, those who take the stain, hematoxin and eosin stain, and those who do not take the stain, the chromophobes, which produce the growth hormone and prolactin. But the chromophils, there are those who take the red color, the acidophils, and there are those which take the blue color. And all this, of course, in the anterior pituitary, and each one of them produces a group of hormones. But let's concentrate on our hormone today, which is the FSH. We know that FSH, these four hormones, FSH, LH, TSH, and beta HCG, they all have a common alpha chain, which is the top of the picture. While the beta chain, they are all glycoproteins, as I say, and each of them is formed of two chains, an alpha chain and a beta chain. They have a common alpha chain and they have a different beta chain. But it's worth noticing here that the beta chain of LH is very similar to the beta chain of HCG. This is why we can use the beta HCG instead of LH for the final step of ovulation induction. And also, if we are looking for pregnancy, we really have to do a beta specific HCG so that we will not be measuring LH because it is has a very similar chemical structure as the LH. So by that time, this is the FSH molecule. It's a large molecule. As I said, glycoprotein, molecular weight of 22,400 daltons approximately. And on the right side, we see how this large molecule, of course, exerts its function. It cannot go inside the cell, as we can see. This is the cell wall. And what the FSH is doing is that it is attaching itself to the receptor, which is partly inside the cell and partly outside the cell. But what I want to say is that by that time, the chemical structure of FSH was known. It was known through the work of Rathmans and Saxena and Rathmans, as you can see, and also by the work of Colin Howells. So what the Serono and Organon did is that they had a race to produce the recombinant FSH, which is scientifically called polytropin. So there was a polytropin alpha and a polytropin beta. Polytropin alpha produced by Serono and called Gonal F, and was registered or licensed in 1995, while polytropin beta marketed under the name of Purigon by Organon, which was produced in 1996, as we see here, which was registered, licensed in 1996. I'm not going to go into the details of the preparation, but as you know, there are cells. Now, most of the recombinant technology is done in E. coli cells, but in our case, it's done in the ovary of hamster ovarian cells, and you put these cells and you give them the ingredients that needs to be done. These cells, of course, are taught to produce the DNA of these cells is manipulated in order to produce FSH, and then you give it the required ingredients, and then at the end of the day you collect your recombinant FSH, as you can see from this diagram. So now we had on the market different preparations. On the left, we had the original Pergonal, 75 and 75, 75 SH and 75 LH. Then we had our Metrodine, they used to call it Serono Metrodine, which was 75 and 25. Then we had the Metrodine highly purified HP, which contained less than 1 LH. And then finally, we had our Gonal F, which is 100% pure FSH with no LH at all. And this is how it looks like. Of course, the HMG and FSH and the highly preferred FSH, they are dosed in international units. Meaning what? Meaning there is a preparation of FSH which is present in WHO in Geneva, and then you compare every time that the drug company produces its drug, it has to compare it to this preparation in Geneva and give you the dose in international units per milligrams. But in case of recombinant FSH, because it is totally pure, there is no, you can actually use it by mass. You can say that this is by milligrams per milliliter, for example, and so on. So you can define it by mass. And then you can, because people are used to international units, then you can give the equivalent in international units. Now, by time people started to use the recombinant FSH more and more, and this is how things appeared until to the year 2003, using more recombinant FSH and less HMG and urinary purified FSH. So which one of them is better? Now, this is the meta-analysis by Dr. Hisham El-Inani, published in 2003, in which he showed that the clinical pregnancy rate was not really different between recombinant FSH or HMG. And in 2008, he produced another meta-analysis. And in this meta-analysis, he showed that, in fact, the live birth rate with patients who received HMG was slightly better than people who received recombinant FSH. There was no difference in ovarian hyperstimulation. But the live birth rate was better in the cheaper preparations, HMG. But still, the drug companies said, well, the recombinant FSH has its advantages. We can give you an unlimited supply. There's no batch-to-batch. There is no batch-to-batch differences. It produces less allergic reactions. It is less potential risk of infection, meaning that if you prepare your preparation from urine, you always risk to have prions. What we should say here that no case of prions has been prions which produce, for example, mad cow's disease, Creutzfeldt-Jacobs disease. So far, there is no case which has been reported while using human menopausal gonadotropin HMG. There were cases, which were 4 cases actually, which were reported when people were using pituitary HMG or pituitary FSH, but this was something that happened in the early 50s. Professor Carl Gemser from Sweden, this was the way to produce the FSH at that time from the cadavers, from the pituitary of cadavers, and in this case they had some cases with prions, but with human menopausal gonadotropins, so far there are no cases of mad cow's disease. But then the manufacturers say also that the recombinant FSH has a high specific activity, so less acidic isoforms, and again, because of its purity, then women can give it to themselves by subcutaneous administration, and this is an advantage in countries where you cannot just go to the pharmacy and ask them to give you an injection. They will not. You have to go to the hospital. So if you are going to give it under the skin, so people can do it by self-administration. But really, what Dr. Inani said makes sense because of the two-gonadotropin theory. As we know, this diagram represents a follicle. As you can see, the follicle, one follicle, which contains granulosa cells inside and theca cells outside. And what normally happens is that LH, as you can see here, stimulates the theca cells to produce the progesterone and the androgens, which are 19 carbon atoms. But in order to transform the androgens into estrogens, or in fact to estradiol, in our case here, you have to remove the carbon number 19 by the enzyme called aromatase. So this is an aromatase or aromatization, and this can only happen in the granulosa cells inside the follicle. So we need LH in order to, and we need FSH. So if the lady has hypo, has no LH at all of her own, and you give her pure FSH, then there will be no response. The other thing that we should remember is that if we are giving GnRH agonist, if we are giving it with a strong dose so that you really abolish all activity of the hypothalamus, the pituitary, and you do not have any LH, then this woman cannot produce estradiol because you need LH, you need priming with LH before giving the FSH. And this is the so-called two-cell two-gonadotropin theory. Shown here again in the upper panel, this is the theca cells, and the lower panel is the granulosa cell. And the theca cells, as we said, they use cholesterol to produce our androgens, progesterone and androgens. And these androgens go inside the granulosa cell, but they cannot produce estradiol is only produced in the granulosa cells because it contains the aromatase enzyme. So what did the drug company say? They said, okay, we are going to produce a recombinant LH for you. If you really have a patient who is hypo, who has no LH at all in her system, then you can, of course, add the recombinant LH. So now you either give LH recombinant with the recombinant FSH if you need to give this LH, or you give HMG. Now, this recombinant HCG or recombinant LH, is it as good as giving urinary HCG? Because our HCG, which we give it to for the final act of ovulation induction, we give HCG. Now, this HCG is made from the urine of pregnant women, as you probably remember. It's produced from the urine of pregnant women because it's the urine of pregnant women which contains high levels of HCG. So it is used instead of the LH. But we can always use the recombinant LH. It is more expensive, but we can use it. But which one of them is better? None of them is better. They are both the same, as shown here in this Cochrane review by Dr. Yusuf from Cairo. Now enough for the FSH and LH preparations. What about the agonist protocols? In 1982, this paper came from the group of Glasgow, Professor Richard Fleming and Ian Coates and Professor McNaughton and David Barlow and others, the group of Glasgow. The company called Hoxton had produced this drug called Suprafact. They said that this is a GnRH agonist, meaning what? Meaning that it resembles GnRH, but it actually produces the opposite effect. In fact, it produces 3 days of stimulation followed by depression. So by giving this drug, you are actually doing down regulation of the pituitary. And in this paper, this was not a paper on IVF. This was a paper on patients with polycystic ovary syndrome who had been given HMG and they did not become pregnant. So the idea of this paper is that these patients could be given this preparation which will remove all their hormonal activities, and then we will start to treat them from afresh. So they were giving this preparation, which was giving a transnasal sniffing until there was downregulation, and then they were giving the HMG for stimulation, and many of them became pregnant. So this was the first principle of doing downregulation in reproductive medicine. Now, after that, other drug companies came with other preparations, giving, for example, by intramuscular or subcutaneous injections like decapeptyl. And these are the preparations. As we remember, GnRH is a decapeptide, 10 amino acids. So what the drug companies came is that They came at amino acid number 6, which is glycine, and they kept removing it and putting something else and producing for us the leuprolelin, goserelin, nafarelin, triptorelin, and buserelin. And all of them are preparations which are in fact GnRH agonists, meaning they produce a flare-up for 2 or 3 days, followed by depression of the pituitary. And this is how people started to use it. So people, when this preparation was available on the market, some people said maybe we can use this protocol in order to program our ovum collection day and our embryo transfer day. We do not really want to come every day, because at that time we used to go every day, Saturdays and Sundays, because of ovulation. But if you had this preparation, you could actually program your cycle. You could wait for the weekend without giving the lady anything and then give her your HCG at the day, so that you can program your cycle. So this is how it started, by giving the GnRH long protocol, meaning that the patient would come on day 21 of the previous cycle, and then we would start giving her the GnRH either by sniffing or by subcutaneous injection. Usually today we give subcutaneous injections. And then she would have usually a cycle, so she will come on day 1 of the cycle, when we would start the FSH stimulation. Now, at that stage, we can put down the dose of the GnRH agonist protocol. We would continue, aided by measuring estradiol. We can, in fact, measure estradiol before starting FSH to make sure she is down regulated, and then we give the FCG, FSH together with GnRH, and then when the follicles are reach the specified size, which is usually 18 millimeters, we give our HCG and go for ovum collection 32 to 36 hours afterwards. But this of course takes a long time. So people have come up with the GnRH short protocol, meaning that the patient would come at the beginning of the cycle, then given the FSH and the GnRH agonist at the same time at the beginning of the cycle, or 3 days after starting the cycle, and the idea is really to prevent the LH premature lysis. There was also the ultra-short protocol, and the ultra-short protocol is meant to use the 3 days of flare-up. Sometimes it is called the flare-up protocol, and this protocol is good maybe for patients who are poor responders. So we use this characteristic of the GnRH just to produce some flare-up at the beginning of the cycle, just for 2 or 3 days, as you can see in this picture. I must add that there is another protocol, long protocol, which can be started on first day of the cycle. So the long protocol can be done. It can be a luteal long protocol, mid-luteal protocol, as you can see here, but it can also be a follicular long protocol. Then the woman would come on day 1, she would start the GnRH, and she will disappear for 2 weeks and come back, measure the E2 and see if it has come down and she is okay, down regulated. Then we would start giving her the FSH at that stage. And what happened at that time, people started to use the long protocol, and Hughes in 1992 produced this meta-analysis. He said that this long protocol seems to be much better than the HMG only protocol. And in this meta-analysis published in Fertility and Sterility, as I say, in 1992, he showed that the clinical pregnancy rate per IVF cycle commenced was better the clinical pregnancy rate per embryo transfer was better and cycle cancellation was diminished. However, as you can see, there is nothing about the live birth rate. And of course, we are always interested in the live birth rate. So, but however, people have found that the long protocol was a practical protocol and they were happy with it. So everybody continued using mainly the long protocol, with some people using the short protocol. But it was clear from the beginning that this long protocol is associated with a higher incidence of ovarian hyperstimulation syndrome. This is the FIVNAT, the French registry of IVF, and showing here in 1989 that ovarian hyperstimulation with the long protocol was 4.5% as opposed to 0.6% for the HMG only cycles. What came after this is that in order to prevent ovarian hyperstimulation, drug companies like this pen, they produce a pen. And the idea of the pen is that, first of all, it can be self-administered, and number two is that you can use a flexible dose. So if you want to give a smaller dose, you can give a smaller dose, because Roy Humbur had come up with this chronic low dose step-up protocol, meaning what? Meaning that in patients which are liable to hyperstimulation, like the polycystic ovary syndrome patients in particular, we can start, as shown here, with a small dose, like half an ampoule, 37.5, or an ampoule for 7 days, and then see the patient after 7 days and see maybe increase the dose by 50%, and then again for 7 days or 4 days, and do another scan and increase the dose until we get a dominant follicle before giving our HCG. There is also the step-down protocol by the Japanese group led by Mizunuma. And as you can see here, he would start here by an ampoule and a half, 112.5 to 2 ampoules and a half, but then for 4 days, and then decrease it to 1 ampoule for 3 days, and then again diminish it by another dose. So until again you have a follicle of 16 millimeters or 18 millimeters, and then give your HCG at that time. So as you can see here, these are the pens used for this protocol. Now we come to the antagonist protocols. As we said, the agonist protocols, the agonists, GnRH agonists, produce a flare-up for 2 or 3 days before doing the down regulation. But then the drug companies came up with the antagonists. They say now we have drugs which are totally antagonist. They will start the down regulation from the time you give them. And this is how they manage with the decapeptide, the GnRH, which is decapeptide, as you can see, and they kept changing the amino acids, as you can see here, to produce the citrullyrics, the ganirelix, and the different antagonists on the market. And the way we give these antagonists is either fixed dose protocol, see the patient on day 7. Then in this case, of course, we start our FSS stimulation on day 1 of the cycle, day 1, day 2 of the cycle. And then the patient will come at the 6th day or 7th day of the cycle. So we can give her 1 bolus of 3 milligrams, or we can divide our 6 milligrams into half a milligram every day for 6 days, starting from day 6 of the cycle or day 7 of the cycle. Then there is a third method, which is the flexible protocol. We would not be strict about our day of starting the GnRH antagonist protocol. We do this when the follicle reaches 14 millimeters. So when the follicle reaches 14 millimeters, we would start giving her the 0.5, the half milligram of our subcutaneous preparation. Until the follicles reach the size we need, we give then the HCG as shown here. So these are the different antagonist protocols. You have the single dose protocol, which is 3 milligrams on day 7 or day 8 of the cycle, or the multiple dose protocol, which starts on day 6, giving half or 1/4 of milligram per day, and then you have the flexible protocol, giving 1/4 milligram per day, starting with a follicle size of 14 millimeters. But actually, these are the two protocols which are more commonly used. So this is the first one in the upper panel, which is the long agonist protocol, starting day 21 from a previous cycle, as I said, or the antagonist protocol. Again, most of the people who use the flexible protocol start the HMG or the FSH, and then ask the patient to come on day 7 or 8, and then give her the antagonist when the follicle reaches 14 millimeters. So, is the agonist protocol better or the antagonist protocol better? As you can see from this meta-analysis by Hisham El-Inani from Cairo University in 2009, he said that the live birth rate with the agonist protocol was better. And this is 2009. He said the live birth rate was better, but the antagonist protocol had its own advantage, which was to diminish the ovarian hyperstimulation syndrome. So yes, the antagonist protocol is very good at diminishing the ovarian hyperstimulation syndrome, but it is associated with a lower live birth rate. At least this was what Hisham Inani said in 2009. But by 2011, he produced another meta-analysis, a Cochrane review, in which he said, no, it seems that people did not use it properly. It was a learning curve. Therefore, this is why people were not producing good results. But when they had good learning, and also because they were using the antagonist protocol for only the patient which were not very good. So by that time, by 2011, things looked like this, and then most of the people today would tell you that the agonist protocols and the antagonist protocols have the same live birth rate, or associated with the same live birth rate, as you can see from this Cochrane review. While of course the antagonist protocol keeps its advantage as the best one to diminish the ovarian hyperstimulation syndrome. So the advantages of the antagonist protocol will be that it is a shortened duration than the long agonist protocol. Obviously, it produces the same results as the long protocol concerning live birth rate, and it has a lower incidence of ovarian hyperstimulation compared to the long agonist protocol. So it's probably the preferred protocol for patients with polycystic ovary syndrome. And these are the agonist and antagonist protocols, as I said. Starting from below, we have the antagonist protocol. Then above it, we have the long mid-luteal protocol, which starts on day 21. And above it, we have the long follicular protocol, which starts on the first day of the cycle. Then we have the short protocol, and then on the top, we have the ultra-short protocol, or the flare-up protocol, where you only give 3 days of GnRH agonist, and then you start your FSH. While the short protocol, you give your agonist and you continue with the agonist together with FSH. So you keep giving your agonist until you give your HCG. Now we have the mild stimulation protocols. What are the mild stimulation protocols? People started saying, well, these protocols, you keep stimulating the patient to produce 30 oocytes and sometimes 20 oocytes or 30 oocytes, and then after all this you tell us put back one embryo or two embryos. Why are we bombarding the ovary with all these stimulation? Of course you can argue that you have freezing, you have many oocytes, you have many embryos, you put some of them and the rest you freeze for future transfer. But again, people say, well, some people say, well, we don't really need to bombard these ovaries with these strong doses of HMG. Why can't we go a little bit slower or softer protocols? Now, people have different definitions, but really we have to use the terminology produced by the ISMAR Society, the International Society for Mild Approaches in Assisted Reproduction, which is the following. You may be talking about natural cycle. Natural cycle is using nothing, no medication, like Stepta and Edwards did in the first cycle of IVF. You just observe the patient, measure the LH, and when the LH starts to rise, you go for the ovum collection. But there is the second entity is the modified natural cycle, which means that you don't give stimulation, but you measure your LH, and then you may like to give something to trigger the ovulation. So you would give the HCG, or sometimes people give the GnRH for stimulation, or you may like to give an antagonist in order to prevent any possibility of an LH rise. So these are the modified natural cycles. So you have the natural cycle, you give nothing. The modified natural cycle, you don't give stimulation, but you trigger with HCG and sometimes with or without giving antagonist in order to prevent the LH. Then we have the mild stimulation protocol. The mild stimulation protocol with the aim of producing 2 to 7 eggs. We don't need 20 or 30, in which case you give a smaller dose of HMG or FSH, and sometimes with or without clomid or any other tablet, and then give a GnRH antagonist so that in order to prevent the LH, any LH rise. And then finally, we have the conventional protocols about which we have been speaking previously, the agonist protocols and the antagonist protocols. So this is mild stimulation. When we say mild stimulation, we mean mild doses of FSH, a GnRH antagonist with or without oral. And this is the one. Mild stimulation means low dose HMG or FSH. And then you give your antagonist in order to prevent LH, and then you trigger with your HCG, or sometimes you trigger with an agonist, as you can see from here, with or without clomiphene or letrozole, as you can see here again. And what's the idea? For this idea, we really have to remember this FSH window. What is the FSH window? What happens in normal cycles, as you can see from the left panel, is that we have oocytes growing all the time. They grow and regress, they grow and regress, they grow and regress, except if the follicle is growing at a time when FSH is high enough, has surpassed a certain threshold. Now, this follicle, which happens to be growing during this window, will continue, and then it will reach dominance, and then it will be the follicle which will ovulate in this cycle. Now in the middle panel, as you can see, if we are giving stimulation to this lady with high doses, then we are rising the level of FSH to a very high levels, and then our window of FSH is going to be quite wide, in which case all the cycles which were meant to regress do not regress, and they carry on producing mature follicles, as you can see, multiple follicular development. While on the right panel, this is mild stimulation. Yes, you stimulate, but again, you don't open your window as much as in the middle panel. So this is the idea of playing with this FSH window, making it very wide or making it just wide enough to produce our 2 to 7 oocytes as in mild stimulation. Now, what is the difference between the mild stimulation protocol and the conventional protocol? As you can see here, the mild stimulation produces a lower a number of live birth rate and ongoing pregnancy rate, at least in this meta-analysis by Matt. But still, people like sometimes to use mild stimulation protocols or sometimes even natural psych protocols. And why would we use this? Now, there are places where you have low resources. In certain countries or certain places, people don't have enough resources. So you can still do your IVF with a smaller amount of stimulation. Also, you can have a patient for whom FSH is contraindicated. She has a malignancy for which she cannot have very strong ovulation. Then again, for poor responders means what? You give a strong dose of HMG and the patient produces 2 or 3 oocytes. And you give a smaller dose of HMG or FSH, she produces 2 or 3 oocytes. So why do you need to give a very strong dose if at the end it's the same amount of oocytes she's going to produce? So some people do this. They don't like to stimulate strongly with in poor responders. And then finally, of course, we have to respect the patient preferences. Some patients just don't want to use too much hormones or don't want to use hormones at all, or they had previous problems or hyperstimulation problems in the past, and then they will ask you not to use this protocol or the other protocol. And finally, we come to the double or the Shanghai stimulation protocol. Meaning what? Now, in this protocol, the patient is stimulated, as you can see here, is treated twice. As you can see here, she is giving HMG, and then in this particular case, triggering was done by GnRH agonist, and ovum collection was done. But then we asked the patient to wait for 2 days and we can come back and have some more HMG, until the follicles again are big enough, and then we trigger again. In this case was triggered by HCG, and then we do our ovum pickup. So why would you do this? As you can see here, the indications, again, poor responders. The patient had a dose and she collected 1 or 2 eggs. Maybe we can see that there are some smaller eggs which can grow a little bit more, some smaller follicles which can grow with some more stimulation. Then you do some more stimulation and you do the collection. Post responders. Or for fertility preservation, a patient with cancer, for cancer patients, a patient with cancer, she's coming, she doesn't have the time, then we have to start stimulation, and we can start our stimulation at any time, in fact, and then trigger with our HCG, collect the oocytes, then continue HMG stimulation, FSS stimulation again, and try to collect another time, so that in order to have enough oocytes. And then again, for polycystic ovary syndrome patients, sometimes you see the patient and you can see that she is not producing enough she is producing too many oocytes, so you collect some of them and then you wait for a few more days. We're giving some booster dose or nothing at all, and then giving another GnRH agonist, and then collect some more oocytes and relieving her from the ovarian hyperstimulation syndrome. Then, what we should remember here is that, of course, if we do the double stimulation protocol, we will need to have a good freezing program, because we are not going to replace our embryos in this particular cycle. Of course, we will wait until a future cycle, during which we will do our frozen embryo transfer. So this is the summary of what we have been saying today. We have a natural cycle, IVF, giving nothing, modified natural cycle, giving no stimulation, but adding HCG and sometimes GnRH antagonists to prevent the LH rise. Mild stimulation protocols, where we would give a smaller dose of FSH and then GnRH antagonists to prevent LH, and then give it RHCG. The agonist protocols, the long mid-luteal protocol and the long follicular protocol. Then we have the short agonist protocol and the ultra-short agonist protocol. Then we have our antagonist protocols, the single dose protocol, the multiple dose protocol, and the flexible protocols. And finally, we have the double stimulation or Shanghai protocol. So which protocol should we be using? Now, as you can see, people have come up with algorithms to help us choose the appropriate stimulation protocol. And as you can see, on the left side, we have the algorithm of Nelson, which was published in 2009. And what Nelson et al. Says that if you, depending on the level of AMH, if you have a low level like 1 or less than 1, maybe one should use the modified natural cycle. Between 1 and 5, then one would expect a poor response, in which case one should use the antagonist protocol and then increase the dose of FSH, make it like 300 international units every day. While between 5 and 15, then this is the expected normal response. And then one should go to the traditional agonist protocol, maybe a long protocol, and using 3 ampoules, which is 225 international units per day. While if the AMH is higher than 15, then one would expect a high response, in which case one has to be cautious, and then in this case use the antagonist protocol again and diminish the dose of FSH and maybe start with 2 ampoules only a day, which is 150 international units. Now Yates et al. came up with another algorithm. It's nearly the same thing really, but different in the levels, the cutoff points. The other question is, what dose should we be starting with? And Lamarca and Sunkara came up with this nomogram, which is again based on the level of AMH. Now, what did they say? They said that if we know the level of AMH and we know the level of FSH on day 3 of the cycle and we know the age of the patient, then by drawing the lines, as you can see, we come up with the best starting dose, which is in this case was 150 international units, which is 2 ampoules a day. Again, they came up with another nomogram based on AFC. And again, as you can see, if we know the age and we know the FC and we know the FSH on day 3 of the cycle, then we can start with 2 ampoules a day, again, as you can see from this nomogram. Another suggestion was the one suggested by the Poseidon group, as you can see here. They classified patients to 4 groups really. The young patients who are less than 35 years of age and those who are equal or more than 35 years of age. And again, each one of these groups is either a good responder or a poor responder. So group 1 are the less than 35 and good responders. Group 2, more than 35 and good responders. Group 3, less than 35 and poor responders, while group 4, more than 35 years of age and poor responders. But then, does this strategy work? Now it's apparently still early to say if it works or not, because according to this study by Nebo Anderson and others like Juan Garcia-Vizarco and Bart Fauser, as you can see here, they individualized the patients according to the level of AMH. And as you can see, by doing this, they found similar efficacy and improved safety. Meaning what? Meaning that by doing this individualized treatment, they could not improve the results in terms of pregnancy, but they could prevent ovarian hyperstimulation by diminishing the dose of FSH in cases where the AMH was high. So improved safety with similar efficacy. Again, another study by Van Tilburg, Italian, another multi-center study, again, and they divided the patients into the poor responders here in this slide. Poor responders, again, this individualization did not improve the cumulative live birth rate. While the second part of the study, which was concerned with the predicted hyperresponders, again, there was similar cumulative pregnancy rate, but lower occurrence of any grade of ovarian hyperstimulation, again, reaching the same conclusion. You cannot improve the results, but you can prevent ovarian hyperstimulation by individualizing your treatment. So really what we can say here is that either that these monograms and these strategies do not work, or that it is a little bit early to reach conclusions. Maybe they are using the wrong nomogram. Maybe we should have some improvements on the classification and the suggesting newer nomograms. So in conclusion, ladies and gentlemen, the long agonist protocol and the antagonist protocol have similar success rates, but the antagonist protocol is associated with a lower incidence of ovarian hyperstimulation. It also offers the possibility of triggering ovulation with the NRH agonist instead of HCG in susceptible cases, and it is also less time consuming. Mild ovarian stimulation protocols are patient friendly and are less expensive, and they can be used in poor responders, patients with previous ovarian hyperstimulation syndrome, and in low resources communities. While natural and modified natural cycles should be reserved for patients with contraindications to FSH stimulation. The double stimulation protocol, or the Shanghai protocol, offers advantages for oocyte freezing in cancer patients as well as in poor responders. And finally, individualizing stimulation protocol is still being evaluated, and we are waiting for the verdict on that matter. And with this, I come to the end of my presentation, and I would like to thank you very much for your attention.